Okay, good morning, everybody. So I'm Jeremy Herschler, Dr. Herschler, for those of you who haven't met me. I'm an addiction psychiatrist at WVU, and I'm going to talk about how to help challenging patients with addictions. And that's really kind of the bread and butter of being an addiction specialist is people are going to turn to you to help resolve and treat cases that are difficult for everyone else to treat. So I'm going to talk about some strategies to accomplish that. And I really love this sculpture. This is the Freedom Sculpture in Philadelphia. It's at the former GlaxoSmithKline building, and the artist is Zenas Frudakis. So I think that kind of captures the emancipation of somebody from the throes of addiction. So I have no conflicts of interest to disclose. And so here's the objectives of what we're going to discuss today. So what makes an addictions case challenging? And basically that boils down to the complexity of the case. That's what makes it challenging. And so I'm going to describe how complexity impacts outcome. I'm going to talk about how to formulate cases. I'm going to describe the module strategy to address patient complexity. I'm going to cover an overview of treatment approaches. I'm going to discuss the scientific basis for recovery, and I'm going to cover an overview of recovery strategies, and then we'll go over some sample cases and have some conclusions. All right. If you guys have any questions along the way, feel free to ask questions. This can be kind of a discussion. I don't have your images on the screen so I can see the slides, so just speak up if you have a question, okay? So Ralph Waldo Emerson said, bad times have a scientific value. These are occasions that a good learner would not miss. So while complex and difficult cases and addictions are upsetting and challenging, it is an opportunity for us to become better clinicians to learn how to tackle these most difficult cases. And so when I work with the addictions fellows, I always encourage them to welcome challenging cases and work with their supervisors to figure out how to treat the most difficult cases, because then everything else is kind of easy by comparison. So what percentage of patients with drug addiction relapse? Well, actually, it's about 40 to 60%, so pretty high, but it's like other chronic illnesses like diabetes, hypertension, asthma. All these chronic illnesses tend to have high relapse rates. And so there's lots of room for improvement. And so right along the lines of what I was saying with Ralph Waldo Emerson's quote, there's an African proverb that says, smooth seas don't make skilled sailors. So if you're going to become a skilled clinician, you have to have some challenges. So let's talk about what the tough cases are. Now in addictions, they talk about somebody having a monkey on their back. I don't know if you guys ever heard that before. But this is kind of how serious the life disarray can be of somebody with an addiction. You know, it's like having an octopus on your back. It's pretty apparent there's something going on. So the traditional medical model applies only to straightforward cases. And so with the medical model, you have like an unmanageable pile of snakes, all the symptoms that the patient presents with. And that can be reduced to a single manageable snake. And what I mean by that is that we take these collection of symptoms and narrow it down to a single manageable diagnosis. And then we make an evidence-based treatment approach related to that diagnosis. And so hopefully what we're trying to do is address the root cause of the problem. But you're going to see that these complex cases are different than just a single manageable snake. So with complex cases, you need to have pattern recognition. And you want to apply the best evidence-based principles to the whole clinical situation. And for many patients, the complexity landscape is crowded and uncertain. There's a lot going on, and it's difficult to ferret out what all the factors are that contribute to this patient's difficulty in responding to treatment. And so in the addictions field, we have multidisciplinary teams. So there's people with lots of different lenses, from a psychiatrist to a social worker to a counselor to a nurse to a medical assistant. So everybody's putting their lenses on this patient and contributing a big picture to what's going on with the patient. And ideally, we want to break these complex problems down into modules. And I'll explain what I mean by that. And then we want to integrate the solutions into a coherent whole. So what do I mean by the work streams are modularized? Well, basically, we're breaking down the journey of recovery into small steps. And if you find what the modules are, it can reveal talent gaps in an addictions program. So if there's some kind of problems that patients are having in their life, and you don't have a way to address those problems, that's going to be a difficult aspect of the care of the patient when you're treating addictions patients. And so a taxonomy into modules allows the program to develop a response to the group of problems that the patients face, a clear response. And so you want to align the patient's needs and pain points with the right people and with the right instruction manuals and the right approaches to each of these needs. So what makes a case complex? Well, Dave McDuff, who is an addiction psychiatrist and sports psychiatrist in Baltimore, Maryland, he has developed a model of complex cases, and I kind of added to his model to kind of increase the number of factors that can contribute to complexity. And so here's I think there's 10 of them or 11. So here's the different factors. So first of all, multiple substances make a case complex, and especially when there's upper-downer pairing. So Kantian had a theory that people self-medicate with drugs of abuse or alcohol. And so they're trying to ameliorate some anxiety or some depression, or they're self-medicating. And so that would make sense. If someone's depressed, they would want an upper. If someone's anxious, they'd want a downer. But when people use a combination of uppers and downers, it doesn't really fit into that Kantian self-medication model. And so it's more complex when you're treating people who are using, for example, methamphetamine and opiates, or where they're combining those uppers and downers. And then risky routes of administration make cases complex. So what makes a drug most habit forming is the speed of onset of action. And so if a patient smokes a substance, it gets into the lungs and goes to the brain almost immediately. And it's also very rapid with injecting. Whereas if someone ingests a pill and they have to digest it, it's a more insidious onset of action, and it's not going to be as habit forming. So it's that speed of onset. And so with smoking and injecting, you really have a rapid onset of action. And so it makes it more complex. And then also psychiatric comorbidity, medical comorbidity, cognitive impairment. So all those factors can increase the complexity. And then if someone is underemployed or they have a low education, so that can make the cases more complex. And concurrent dealing or criminality, that makes cases complex. Ongoing trauma and loss make a case more complex. Addiction during pregnancy is an added factor that makes cases complex. And then multiple concurrent addiction types. So someone may have a sex addiction or a gambling or shopping or video gaming or internet addiction, or even food, that somebody may have a binge eating problem that really kind of fits into an addiction sort of behavior. And so all that can make addictions more complex. And then you can have complex social factors. So if someone's associated with a marginalized group or a gang, that kind of affiliation can make cases more complex. Or if they're in a culture that's associated with high addiction stigma, so where the person is like shunned from the community because of their addiction, that can make the case more complex. And then also serious family dysfunction and divorce can make cases more complex. And then languishing is something that I'm interested in. It grows out of the positive psychology field. And basically what languishing is about is being stuck in some unpleasant situation. And so there's like persistent dysfunction in their relationships and work or school, poverty, homelessness. So they're stuck in an unpleasant state and no movement and no ambition to get out of it, or hopelessness and helplessness and getting out of it. So that languishing makes a case more complex. And then early life and late life addictions cases can be more complex. When I worked in Baltimore, I did my addictions fellowship in Baltimore, and I did a rotation in Annapolis at Pathways, which is a rehabilitation program there. And there were very young people who were in the throes of addiction and involved in all kinds of behaviors related to addictions at age 13 or 14, really having trouble with addiction. And then there are cases of people late in life who are having trouble with substances. So that can make cases more complex. That later in life, people have more medical issues and other factors that contribute to the complexity of cases. And then lastly, prominent individuals with a significantly developed career tend to be more complex cases, and they have a lot of shame, in their social group. In most cases, with people who are prominent figures, there can be a lot of shame related to the addiction, and also their impairment related to the addiction is affecting so many other people because they're holding important occupational positions and their families are important figures, so the impact can be more devastating in the environment that they're in. So let's look at some of the data. There's not a whole lot of data about complexity that I could find, but this is a little bit older. But in 2014, 43.6 million Americans had some form of mental illness, and 20.2 million had a substance use disorder in the last year. And out of that 20.2 million, 11.3% had both an alcohol use disorder and an illicit drug use disorder. And 7.9 million had both a substance use disorder and a mental disorder. So you can see how the complexity is pretty common. And then even for pregnant women in 2012, 6% of pregnant women use illicit drugs and 8.5% were drinking alcohol. So there's a pretty common, this is almost a norm to have some sort of complexity going on. Now, there's an instrument called the Addiction Severity Index. And I worked with this when I was employed at the VA Medical Center in Baltimore. We used the Addiction Severity Index to assess how severely affected by the addiction and all the things that are aspects of addiction in the person's life. And so it's a general overview of the substance use problem, and it's divided into 7 functional areas that are all related to substance use. And so you've got medical status, employment, drug use, alcohol use, legal status, family and social status, and psychiatric status. And so McClellan, who developed the ASI, has some research that's shown that patients who re-enter treatment programs are often presenting with more severe addiction problems. And what's happening is that they have problems or difficulties that weren't being addressed adequately in the previous episodes of treatment. And so the ASI profile was more severe in those people who re-entered treatment, and they have more needs than those who responded after the first time they were treated. Now I want to talk about how change works in these complex cases. And Rusk and that group in 2018 had an article about complex system change. And so just one change in a single module may fail to tip the system into a new stable state. And so relapse can occur if there's just one change. And when there's changes in multiple modules, then it can have a synergistic effect that enables the system to tip into a stable pattern. And also, unchanged parts of the system can undermine the attempt to change, leading to relapse. And changes in one module can spill over into others through interactions between domains, and that can tip the system into stability. And also, lastly, particularly potent changes in the system and those with a good fit for the individual promote useful changes, and there's like an upward spiral of an effect on the whole person's life as they make changes that are a good fit for them. So here's a diagram of what I'm talking about. So if you, in the first A section there, you have 5 aspects of functioning, and in B, there's one change, one module is changed. But it relapses in C because there's not enough to tip the balance. But in D, you have multiple modules changing. And so in E, the balance tips, and then in F, you have a stabilization in this new state. And so the key here is to impact as many different needs as you can. And so when I worked with a methadone program, we looked at the ASI and really realized that you had to meet the needs of the patients as much as possible. And the more needs you can meet, the more stable the patient's going to be in recovery. So this is the Center for Hope and Healing. I don't know if you guys got to see the Center for Hope and Healing, or tour it, or actually do a rotation there. But this is the 28-day rehab program that we have here at WVU. It's over in Milan Park. And Dave McDuff, who I mentioned, the addiction specialist in Baltimore, says that addictions treatment basically involves cutting down or stopping, getting comfortable, establishing life balance and lifestyle change, and then finishing trauma work and personal growth and development. So a very key element of addictions treatment is motivation enhancement. And I'm sure you guys had a lecture about motivational interviewing. But the key element here is developing a discrepancy between where life is now and where they want it to be. And when you do that, it creates leverage. And leverage can come from all kinds of things. So it can be pressure from their family, or their work is going to pressure them into changing their behavior, or they have medical consequences and that makes them want to change, or they overdose and that makes them want to change. So there's always, you want to have some kind of leverage to motivate the person to change their behavior. And so you're always kind of looking, where's the leverage? You got to find leverage. And then so also aversive substance related experiences can be critical moments motivators. So like an overdose, or they lost a friend, or a parent died and they want to honor the memory of their parents. So some kind of experience can be a moment motivator. And so when you're motivating somebody, you get from resistance and denial to a place of readiness, and then to a place of motivation. And so what you're trying to do is get someone from a pre-contemplative state to a concerned state. And then from concern, they get convinced and then committed, and then ultimately build confidence. And what patients will tell you is that it's like a light turned on. Something just gets through to them, something clicks, and they kind of get it. So what are some other aspects of addictions treatment? Well, there's something called cognitive behavioral therapy, where we look at relapse prevention. And the key to this is to think of high-risk situations where relapse is likely and prepare for those. Have a toolbox of approaches to deal with the toughest situations that the patient will face. And so if they can think that through and be prepared for the toughest situation, then they're ready for anything, really, if they can tackle the toughest ones. And then 12-step facilitation and mutual support. So if you're familiar with AA and NA, and there's Celebrate Recovery and Smart Recovery. So these are organizations that have mutual support groups where patients can work through steps of recovery. But most importantly, in the mutual support groups, they meet people who are doing well, and they have stories a lot like their story. And so they feel motivated, that they're inspired by these people because they're doing so well, and it makes it believable. When you see somebody who's successful, it makes it believable that you can do it as well. And so there's a kind of psychotherapy called 12-step facilitation, where you work with the model of the 12-step model. And then network therapy is where you get the family involved and other people who are concerned about the individual with a substance use disorder, and they may transport them to meetings or to their clinic appointments. They may give them their antabuse or their other medication, to make sure that they're getting the medication for their substance use disorder, and not enable them so they won't have alcohol in the house, or They won't give them money randomly that they can spend on drugs. So using a network of family to support the recovery of the patient. And I'm sure you've heard about pharmacologic treatments. So the FDA treatments that we have, approved treatments that we have, are for nicotine, alcohol, and opiates. There's some off-label treatments of cocaine and even methamphetamine and marijuana. So some other treatments, but the only FDA-approved ones are for nicotine, alcohol, and opiates. And then acupuncture has been found helpful to some degree. Group therapy. So there's like an inspirational group membership when somebody is in part of a treatment group for an addiction, and they feed off each other, and they're all on the same mission together. It's inspiring. And we in the Coke Clinic, I know you guys have attended some of our opiate use disorder treatment groups, and you can see how powerful the group therapy can be for patients. Then something called mindfulness, which it grows out of the Buddhist kind of psychology, can be helpful for addiction. And basically what happens is patients through a practice learn to kind of step back from their thinking and emotions, not be engulfed in emotions that they're experiencing. They kind of can step back and be a witness to their consciousness. And that can be very helpful for someone who has an addictive disorder. And then peer coaching. So kind of like the 12-step facilitation, having a coach somebody who's in recovery themselves can be a wonderful insight for a patient and make it believable and can kind of guide them in their own treatment and recovery. So there's different levels of care in addictions treatment, and the level of care should be based upon the patient's needs. So the American Society of Addiction Medicine has established kind of criteria for each level of care. And so the levels of care are early intervention, low intensity outpatient, intensive outpatient and partial hospitalization, inpatient rehab, and medically managed inpatient. And so depending on the needs of the patient, you'll assign them the appropriate level of care. And if someone's failing a given level of care, you want to intensify the treatment. So you don't want to dismiss somebody from treatment if they're not doing well. You want to offer them more treatment or a more intensive level of care of treatment. And so that's kind of the approach in general that we use with these patients. And so you also want patients to build self-control. And so how that takes place is for patients to think things through to their consequences. And this includes unintended consequences and even consequences of consequences. And so what I say to patients, and this grows out of AA and NA, is to play the tape through or think through the drink. And so what I mean by that is, so if you use a substance, where does that lead you? That life doesn't work for you. You've been there already and you see how things fall apart. And so if they can play the tape through, if they're getting an urge to use a substance and they think, yeah, that leads me to all this kind of other trouble, that can help prevent them from slipping back into using. And when patients have urges and they overcome that urge by playing the tape through, it's an important experience for them where they get empowered and feel confident more and more and more that they can deal with these urges to use and cravings. So what about relapse? So there's different factors that contribute to relapse, negative emotions and stress, overwhelming complexity in their lives, interpersonal conflict, social pressure, so like peer pressure, conditioned craving, a lack of satiety, so they have a hunger for it, and mental fatigue. All those factors can contribute to relapse. And then you've probably heard of an addictive personality. I don't really agree that there's an addictive personality per se. However, there are personality traits that are risk factors for addiction. And so those traits are low harm avoidance, high risk taking, high impulsivity, high sensation seeking, poor self-care and self-preservation, and low self-esteem. So all those personality traits can set someone up for having a problem with addictions. So what is recovery? Well, recovery is the sober and productive lifestyle of individuals who have successfully resolved dependence on alcohol and or other drugs. And it's a maintained lifestyle. So the person is recovering or in recovery, they're not recovered. And so it's an ongoing process. The person is always kind of in recovery. And it means learning to live without using drugs or alcohol, even if you have negative feelings or enjoying life. That none of those situations are going to set you up for using alcohol or drugs. And Austin Brown and Robert Ashford, who wrote a beautiful article about recovery in 2019, say successful long-term recovery is a fundamentally emancipatory set of processes. And what they're talking about is that it frees one from the bondage of pathology. So how does the recovery process work? And basically, recovery is about taking care of yourself. So I talk with patients, they say, oh, I have all these people who need me to help them, and I have my work, and I don't have time for myself. And I'll say, the body kind of makes sense the way the body is set up. And if you look at the heart pumps oxygen and nutrients to the whole body. But the first vessel off the aorta is actually back to the heart itself. The coronary artery feeds the heart first before it feeds the rest of the body. And so that's really the key to recovery, is taking care of yourself. You got to take care of yourself. And if that works for the body and the heart, then it probably works. It's a good metaphor for human beings in general. And then the Betty Ford Clinic, their model is that recovery has three components: abstinence or incomplete abstinence, well-being, and giving back. And so I'm going to talk about those three areas of recovery. So we talked about motivation some. That's the most important thing in abstinence. And so every patient that comes to treatment has a why. And basically it's answering the question, how come you're here getting help? What's your why? Why are you getting help? And there's lots of reasons that people pose. It can be the escalating consequences of substance use, pressure from family, friends, employer, legal trouble, health concerns, wanting to be a responsible parent. They're tired of the lifestyle and they want to move forward. But the majority of patients say that it's the escalating consequences that is their why. And that's from an article from Law Day in 2002. So also motivation comes from the importance of emotion-packed goals. And so it comes from that discrepancy between where life is now and where they want it to be. And once they have these goals in mind about how they want to improve their lives, they start to think about, does substance use figure into that? And what's the right doable sequence of moves to get there? And then also surrendering is important to abstinence. And basically what that's saying is that, this life doesn't work for me. I've tried using substances. That doesn't work. And so it requires a surrendering, it's just not an option. And so they have to consider the consequences and realize, that life doesn't work for them. And then we talked about preparing for high-risk situations. So they want to have a toolbox of approaches to deal with the toughest situations where relapse risk is the greatest. And so that may involve calling someone with a long period of sobriety, like a sponsor or someone they know from an AA or NA meeting. It could also mean finding something healthy, relaxing, and enjoyable to do instead of slipping back into substance use. And that might mean taking a bath, a candle-adorned bath, or going for a nice easy walk or hike, or a relaxing drive, or a picnic lunch, or a dip in the pool, or stargazing, or a yoga session, or going to a museum or a coffee shop. So they want to have a whole toolbox of ways to deal with urges. And so you want to think about what those tools could be for them. And then also social group reconstruction is very important. And so the patients need to be aware of the people that are influencing them in their lives. And, in their cell phones, they have numbers of drug dealers and people they use substances with, and they probably need to get those people out of their cell phone so they're not triggered by them. And what kind of foods and drinks and drugs and thoughts and conversations do people invite into their lives? And so you want to have patients surround themselves with solid people who wish them well and support their sobriety, and find a loving mentor too, someone they look up to who can be kind of a guide for them. Good recovery environments are also important. So we have recovery-ready communities with recovery residences and recovery employment environments, recovery educational environments. I know WVU has a program for people in recovery. Drug courts, recovery-oriented community centers or drop-in centers, peer recovery services and recovery coaches, like we talked about before. Recovery community organizations, coffee houses, gyms, recreation centers. And so the community recovery capital depends on the resources available for individuals and their families who have someone with a substance use disorder. And then community recovery readiness is really talking about the resources in general being perceived by the affected public, the families, and the individual who's affected as being useful. And then also stress recovery is important in abstinence. And what that's about is unwinding routines. So stress recovery is the new fitness. We think of fitness as like aerobic fitness and strength and flexibility, but stress recovery is the new fitness. And so you want to have stress in your life to become stronger people, but you have to have unwinding routines to let go and relax and have some stress recovery. And so it's super important for patients to find unwinding routines that are healthy, not substance related unwinding routines. Also, distress tolerance can be helpful. And so patients with substance use disorders may feel that life is so unbearable it requires anesthesia. And so often that grows out of adverse childhood experiences. I don't know if you've learned about that as much so far. And also psychiatric disorders can set people up for having poor distress tolerance. And so one thing that can be helpful is to soften into distress. And so people kind of resist distress and fight against it and struggle through it. But actually it works better to soften into it. Even pain, somebody has pain, rather than resisting it and fighting through it, if you can soften into it, it dissipates. And then also having a dispositional joy. So some people, like spiritual people, are kind of calm and quiet and serene. And that really helps with distress tolerance. So you have something that, a belief that you have or something that you value that kind of creates that dispositional joy. And then also looking at distress as this too shall pass, that hopefully you can see that this is just a temporary situation. And if you can wait through it and be patient, that things will improve. And also detachment, a healthy detachment can help, kind of stepping back from things can help decrease the sensitivity to distress. And then something called stress inoculation can help with distress. And so I think of stress as like a flu shot. When you get a flu shot, they inject the virus into you and your body fights it off. And then when you're exposed to the flu, you're resilient to it, or like with the COVID vaccine. And so stress inoculation is the same way. When you're exposed to something stressful, it's difficult and annoying and you hate it. But you get through it, and then the next time you're exposed to something stressful, you're like, oh, that's not so bad. I've been through so much. So you do get inoculated by stress, but you have to have unwinding routines and be able to let go at times too. And then also distress tolerance can be strengthened by differentiating good pain from bad pain. And so good pain is like the pain associated with fitness or life improvement, whereas bad pain is pathology related pain. And so you can enlarge the concept of good pain if you can find a silver lining in the pain that the person is experiencing. Okay. So also abstinence is related to healthy activities and hobbies, work or education. All these build self-esteem, give life richer meaning and purpose. And probably the most important thing is that it fends off idle time and boredom. And so patients think, the the most important thing to do about boredom is be entertained. And so they're always looking for entertainment, which can lead to substance use. But actually, goals are the best antidote for boredom. And if somebody has goals and they always got something to work toward and think about and plan for and strategize. And so life is not boring when you have goals. Okay, and how about radical shifts in identity? So Brown and Ashford talk about that as being important in recovery. And so what I mean by that is not settling for a stunted identity. That patients kind of get this view of themselves, like a pothead, or they have these identities that are kind of stunted. And so it's who you become that matters most, and kind of moving out of that stunted identity into a strong and distinctive identity. And so people want to build as much as possible a strong and distinctive identity. And so it's like someone viewing themselves as a smoker to viewing themselves as a non-smoker, or building a solid psychological core of lovability and self-worth. And you also identify with those ideas and people you admire. So part of your identity is from people you admire in your life. And then there's something called recovery schemas, which are kind of ways of thinking that can affect recovery. And so a patient may say, I've got something to prove, or I'll thrive in recovery in spite of them, or I love life, so I'm going to recover. Living a good life is the best revenge, or I hope God believes in me, or you bring out my best. So these are all kinds of reasons to have successful recovery. All right, so that's the abstinence portion. How about well-being? So well-being basically falls into three areas of life: love, work, and health. And that's the science of this comes from New Year's resolutions. So if you think about what people make New Year's resolutions about, those are the things they want to improve in their lives. And the majority of common New Year's resolutions are related to these three things: relationships, work or finances or school, and health. And so that's what well-being is about. And so how do we approach this? Well, there can be an assembly of discrete parts, a growth of systems, mitigating problems. And the goal is to have health confidence and look well, feel well, think well, and do well. And so flourishing is about reality, the reality of love, work, and health. And so what do I mean by an assembly of discrete parts? Well, your well-being is related to the right food, empowering yourself through fitness, restorative sleep, having a strong mindset. So like a stubborn hope. Stubborn hope is so important in recovery, and just kind of tenaciously working towards doing better. And a conditional optimism is more important than a pessimism. And mental toughness, so having great self-talk and visualization, and managing the distractions, and being caring and cooperating and trustworthy and responsible, and gliding well socially, and building a favorable reputation among knowledgeable people, having financial security and economic strength, and also individual and family security and a secure sense of home. So, drug dealers really struggle with this. So when you have people in recovery who have been dealing drugs, one of the worst things about that lifestyle for them is how unsafe they feel in their home, because they have people want to steal from them and rob them, or harm them, or so it's just not a secure kind of a life at home for them. And then purpose is so important, so just to have your life in congruence with your values, and building beauty into one's life, making something beautiful of your life, that can be so important in well-being. And then what about the growth of systems? So you want to design the environment in order to stimulate the growth of well-being. And so what I'm talking about is having an enriching environment. Your environment has a big impact. We talked about that in recovery. An environment has a big impact on the outcome of our lives. In medicine, we talk about genes and environment being the most important factors in the outcomes of people's health. And so you can't impact genes too much, but we can impact environment. And so having an enriching environment is going to stimulate the growth hopefully of good well-being. And so you don't want to be passive about your environment. You want to make it great. And so I always talk to patients about the recovery environment and how can you make your environment as enriching and healthy as possible. And so the genius of nature can be harnessed. We can, just the way plants grow in a good environment, human beings grow in a good environment too. And so that's kind of what natural recovery is about. So when patients spontaneously stop substance use on their own, often that's the environment person interaction that helps with the natural recovery. And what about mitigating problems? So patients need to learn to manage the drama and psychological games of life that can distract them from what's important. And also being a problem seeker. So you don't want to just problem solve. You want to be a problem seeker and look around and see what needs to be fixed. And figure out what's wrong and resolve it. And think about what are the basic principles at play. That's the real key to solving problems, is kind of getting down to the basic principles and figuring out how you can intervene with a problem. And then I was talking about health confidence, so looking well, feeling well, thinking well, and doing well. When someone looks well, you see the look in their eyes, they have a gleam in their eyes. They have health confident posture, they walk with confidence. Their gestures display a quiet confidence. And then feeling well, so you can even hear it in the emotion tone in someone's voice. When someone's depressed, you can hear the emotion tone in their voice sounds distraught. And so there can be a quiet strength to someone feeling well and having a positive emotion tone of voice. And then thinking well, so that's the mitigating problems and constructing a flourishing life. And doing well, so that involves your reputation, your confidence, and ultimately, if you're really doing well, you make a mark on the world. And so all that is kind of building well-being and health confidence. And then the last aspect of recovery is giving back. So that means community service work, helping others. When patients who've had some recovery time help other patients in early recovery, it gives them a transcendent feeling. And you guys, we're working in the healthcare field. It's a nice feeling to help people. It gives you that transcendent feeling to offer healthcare to other people and improve their lives and help them with distress. And then citizenship, so be a good neighbor, respect the environment, vote. So all that is about giving back. So why does recovery work? Well, my feeling about this is based on something called neuroplasticity. And so recovery is really about a self-directed neuroplasticity. And what neuroplasticity says is that we get good at what we practice with our brains. And so if we're practicing pathology like drug use or other pathological behaviors, that's what the brain gets good at. But if you're practicing recovery, if you're practicing abstinence and well-being and giving back, that's what the brain gets good at. And it's a self-directed neuroplasticity. And even to go a step further, there's something called competitive neuroplasticity, where if you're practicing healthy behaviors and the brain is occupied with that, there's only so much cortical real estate. And so it kind of competes away the pathology part of the brain. That's going to get taken over by the healthy functioning of the brain that you're practicing. And so there's competition for cortical real estate, which is really why recovery works for these patients in a neuroscience way. And Norman Doidge is the real expert on neuroplasticity if you want to read about his theories on neuroplasticity. So ultimately, we need to develop outcome measures that go beyond days of abstinence to reflect more accurately the general health, the quality of life, and general functioning of patients in recovery. And so ultimately, we want to have an evidence-based science of recovery. And hopefully that'll garden the recovery group so they can have a stronger recovery community and be kind of have a crisp operation in the recovery process. So one very important aspect of recovery is that it's psychologically easier to build a new healthy behavior than to simply rip out the problem behavior as though it were a weed. So this kind of gets back to that competitive neuroplasticity. So it's difficult to just stop a behavior. It's easier if you reduce the behavior and increase another something to have the brain focusing on something else. I hope that makes sense to you guys. So how long does treatment take? Well, in general, patients with serious substance use disorders are advised to stay in treatment for at least a year, but actually evidence kind of suggests that treatment for 5 years really has the best results, and sometimes it's longer than that. But it takes a while for the addicted brain to heal, and so the best outcomes are kind of having a progressively less intensive treatment over a course of 5 years. And also, we'd like to have treatment on demand. So if somebody needs treatment, we should have it available. That's what we really need, is capture patients when they're, excuse me, capture patients when they're seeking treatment. And also have assertive outreach. So to reach out to the population that's affected, to get them, involved in recovery. All right, so we have about 15 minutes, and I've got some case examples. So these case examples are patients that are kind of made up. They're based on composites of cases that I've seen. I've been practicing for 27 years, so I have a lot of experience with doing addictions work. And the cases are not just one individual, but kind of composites of multiple people. So here's an example case. We got a 29-year-old male with a history of severe opiate use disorder, cocaine use disorder, and alcohol use disorder, and unspecified depressive disorder, who's been treated for 2 years with Suboxone, Antabuse, and Celexa. He's very intelligent and enjoys reading the Harvard Business Review. He's supported himself for years by dealing drugs in the local community, and has faced some incarcerations for possession and distribution. He had a long-term relationship with a beautiful young lady who left him because of his persistent languishing state of little to no growth, of not going anywhere. He remained fixated on this woman. He never worked other than some infrequent solo music gigs. Eventually, after years of treatment in which he was rather stable psychiatrically, he relapsed cocaine and alcohol use. He failed intensive outpatient level of care, Antabuse and Campril, and he was sent to inpatient rehab, and following his discharge, relapsed again and then refused to go back to the rehab and was administratively detoxed off with Suboxone. His addictions therapist saw him as entitled and resistant to change. He revealed his guilt and that maybe he was sabotaging himself as a way of punishing himself for past misdeeds. He was feeling particularly guilty for introducing his best friend to drugs, who was living a terrible life in and out of jail. All right, so let me get you guys back on my screen here. So what do you think? What makes this case complex? Any ideas?
I would say the abuse of several different substances.
Yep, so multiple substances and upper downer pairing, right? He's using alcohol and cocaine. So that's uppers and downers, right?
Along with the depressive disorder as well, because I feel like oftentimes individuals with substance use disorders will self-medicate if they do have mental health issues.
Yeah, so he's got psychiatric comorbidity. What else do you see in this case?
The fact that he did, in fact, deal drugs for
Criminality and drug
however
dealing.
long. Sorry, I don't know if it said.
Yeah. What else? I'll help you guys. So he's languishing. His girlfriend left him because he's kind of stuck in this, he's not working. He's kind of stuck in this unpleasant situation. And I think if there's anything else. Well, let's go to the next slide. So let's see, multiple substances, up or down, or pairing, dealing, languishing, criminal history. Yeah, we got them all. Okay. All right. So we want to meet the needs as much as possible for this individual, right? So you have to engage him in treatment and create leverage, try to impel him to see that he can live a better life and have a better recovery group, to have positive social group, reconstruction, and a good environment, right? It seems like the medicines weren't doing adequately. He was on Antabuse and Campril, but that didn't seem to do the trick for him, right? So we need a more broad approach to this guy. All right, so here's a case of zoophilia and cocaine use disorder. So there's a 38-year-old male with no prior psychiatric history who presented with depression and suicide thoughts and plans for suicide in the context of cocaine use, which he was smoking. He feels unsafe and predicts that he will end his life if he doesn't get help. He is a bit childlike in character. His father left the family when he was young. He has an estranged relationship with his stepbrother due to incest. He has never had a depressive episode in the absence of drug use. During his hospitalization, he also reported sex acts with dogs, which is distressing to him. He refused to further discuss this behavior during his hospitalization. His use of cocaine is out of control. It has caused consequences in several domains of life, and he has experienced tolerance to the drug and withdrawal symptoms. So his diagnosis is cocaine use disorder severe, cocaine-induced depressive disorder with onset during withdrawal, and other specified paraphilic disorder or zoophilia. So what makes this guy's case complex?
I think it's pretty apparent that he's experienced developmental trauma.
Okay. So he's got a complex social situation. His father left when he was young. There's incest, some psychiatric issues going on related to that, right? What else? What's his method of using the substance?
Inhalation.
He smoked.
Smoking. Sorry.
So that's a risk factor because he's using a rapid onset of action method of using the substance, right? What else? So zoophilia is actually a psychiatric disorder, but with this guy, he's like using cocaine and having sex with animals while he's under the influence of cocaine. So this is not like a dual addiction, like he's got a sexual addiction as well as a cocaine addiction, right? So you've got multiple addiction types here. That's not zoophilia is that's a psychiatric disorder. It's not really an addiction disorder. But you can see it has a flavor of being an addiction, right? All right, so let's see if we got everything. Multiple addiction types, risky route of administration, languishing. Oh yeah, so he's kind of stuck in that situation. Psychiatric comorbidity, complex social factors, and loss. Yeah, so his father left, so they had some loss. Okay, one more case. Oh, what about treating that guy? So what are we going to do to impel him to get treatment? So we want to do something with his recovery environment. So maybe getting him to AA meetings or NA meetings and get a good social group reconstruction and make a healthy environment and have him play the tape through, think about where his life leads with all those substances, with the cocaine he's using and how depressed he gets. And then he'll need medication for the zoophilia, right? So there's medications that can decrease libido and help with paraphilias. All right. All right, last case. Do we have time? I think we do. All right. So 35-year-old female with a history of PTSD, opiate and alcohol use disorders who was injured in a motor vehicle collision and had several serious fractures requiring surgery. She was started on Suboxone for pain and her opiate use disorder titrated to 12 milligrams, 3 milligrams total dose per day, divided into 4 milligram, 1 milligram, 3 times a day with a partial analgesic response. She is in physical therapy to improve her range of motion. She has intrusive memories of the accident, but no longer has nightmares of it. She denies being under the influence at the time of the accident, and there was no DUI charge. She's taking Zoloft 50 milligrams a day for PTSD. She's able to drive. She doesn't startle as much as she did following the accident, and she now has a softer vigilance. She has degrees in marketing and communication, but works as a waitress. She resumed work at a restaurant, but her environment is filled with substance users, including coworkers at the bar and in the restaurant. She socializes with coworkers and drinks alcohol heavily at times. She was started on Campro and end of use after a period of abstinence from alcohol while in the hospital, but she became non-compliant with both of them after her discharge. She lives alone and there is no one available to supervise her taking the antabuse to guarantee compliance with it. She has been abstinent from opiates with the current treatment with Suboxone. She was raised in a religious family, and they have banished her from the family because of her substance use and, in their view, immoral lifestyle. And the family problems and underemployment are her only perceived consequences of substance use. So what do you guys think? What are the reasons that this case is complex?
I think I would say languishing again. It seems like since she has those degrees, but she's kind of stuck. And then
Yeah, so that's underemployment, right? That's what we call that, underemployment. She's well educated, but she's working as a waitress. Yeah. What else? I'll help you guys. Oh, go ahead. I'm sorry.
I would say the history of PTSD as well.
Yep. So psychiatric comorbidity. She also has pain, right?
Mm-hmm.
That's a physical problem that can precipitate. So untreated pain is a risk factor for substance use, and sometimes treatment of pain can be a risk factor, depending on what the treatment is that's being used. So here we're using Suboxone, which is a safer approach to analgesia. What else does she have going on? What about her family? What's going on with that?
She's definitely experiencing isolation. I'm not sure what her other lines of support are, but I would think that would be important to discuss.
Yeah, so she's got a complex social situation where her family has banished her because of her substance use. There's stigma in the family with this, and so that they kind of banished her, so that can make it more difficult. And then also she's working in an environment where people are using substances, and so there's a lot of triggering of urges to use in her environment. So she's going to need a good social group reconstruction too, huh? Anything else about it that makes it complex? Let's look and see what I have here. Multiple substances, medical comorbidity, psychiatric comorbidity, underemployed, and complex social situation. All right, so we got it all. So interesting cases, huh? You see how complexity works, right? All right, so Charlie Munger, he's the partner of Warren Buffett. They're billionaires, and they're very wise people. So what Charlie Munger said about addiction, one of the most beautiful things I've ever heard said about it. So see what you guys think of this. He says, while susceptibility varies, addiction can happen to any of us through a subtle process where the bonds of degradation are too light to be felt until they are too strong to be broken. And yet, I have yet to meet anyone in over 6 decades of life whose life was worsened by fear and avoidance of such a deceptive pathway to destruction. One should stay far away from any conduct at all likely to drift into chemical dependency. Even a small chance of suffering so great a damage should be avoided. That's pretty wise words from him, huh? All right, so what about the future? So the ability to read the complexity of difficult problems is super valuable in the care of patients. And so not just in addictions work, but in all our medical care, you want to think about, well, why is this case complex and how can I meet the needs of the patient? And I always talk with patients about how I have a stubborn hope. Patients can get demoralized and no matter what's going on, I always kind of have this stubborn hope. I'm a stubborn person, and they appreciate that. It's nice for them, to have somebody with some stick-to-itiveness who's gonna keep plugging away at helping them, even if they're struggling. And ultimately, you just want to get the job done, right? All right, so there's my references. You guys have any questions?
I actually did have a question. So, with paraphilic disorders like zoophilia, how do things like that form? Like, is that more of like an imbalance or based off of, like, I guess, early childhood experiences?
Mhm. That's a good question. So I've seen cases where people develop paraphilias when they're not able to negotiate a healthy relationship with an adult person. So you like pedophiles, for example, seek out children because they can't have a relationship with an adult. And with a zoophilia case, I think that it may be something where so maybe this patient had some homosexual experiences as a child, as an adolescent, and then was rejected severely by the individual. So it becomes unacceptable to have a relationship with a human being because they were so hurt by the experience of being rejected. And so then they may turn toward an animal for sexual gratification rather than a person because persons are kind of off limits for them emotionally. Does that make sense?
That does. Thank you.
Any other questions? So this is the real bread and butter of being an addiction specialist, is contributing to the whole team of folks who are treating patients to address the complexity of what's going on with this person's life and meet the needs as well as possible, and work on recovery. You have pharmacologic treatment and psychotherapy, and the patient does their part, and you work together. Thank you for listening.
Awesome. Thank you so much.
Thank you.